speaking and raise your hands electronically to ask questions. Use the chat function as you wish, raise any questions you want on there, provide feedback, and we'll hopefully pick up any questions from the chat as well so we can address those. So the agenda for today, I'm going to kick off by talking through the challenges to career progression and the nurse consultant role, which is my role. I'm Mary Freeman. I work in ophthalmology in Sheffield. And then we'll have an opportunity to ask some questions and just to talk about anything that you might want to discuss from the presentation. Penelope will then go on to talk about the ophthalmic nurse education, past, present and future, and will share with us some exciting new initiatives as well. Again, another opportunity to ask questions. And then finally, Mel will talk to us about the associate membership for the Royal College of Ophthalmologists. Penelope will then close the session. So we should be finished in about an hour and a half. Before we start, just to remind you of the upcoming events. There'll be a face-to-face event on Thursday, the 26th of June, and that'll be chaired by Mel and Professor Tim Briggs. And then there'll be further sessions to put in your diaries, one on the 28th of September, one on the 14th of December, 29th of February next year, and 25th of April 2024. And it's surprising how the years pass, isn't it? So let's kick off this lunchtime session. So I'll be talking about the challenges to career progression and the nurse consultant role. Just to give you a little historical perspective, Penelope will talk a lot more about this, but to remind us all that approximately 30 years ago, what was then known as the Ophthalmic Nursing Board gave ophthalmic nurses the Ophthalmic Nursing Diploma. This was a robust and comprehensive course leading to a recognised qualification, something that we really valued at that time. Many of the older nurses will remember this, me included. This was disbanded several years later, and the English National Board, the ENB, developed a framework for nurse education, and that replaced the Ophthalmic Nursing Board. And we then adopted the ENB 346, which was the ophthalmic course. In 1999, an independent review recommended the ENB be replaced by the Nursing and Midwifery Council, which is our governing body. From that time, postgrad education really for nurses was subsequently left to local units to develop. And this is really where some of the concerns started occurring, because many units like Sheffield ran their own courses for several years, and these were affiliated with the local university, but more as time went on fell by the wayside. And in Sheffield, this was discontinued about 10 years ago. And sadly, very few centres now deliver ophthalmic courses for nurses in the north of England. I know Manchester do have a fantastic course, but there are very few that are available now for us. And it's for this reason that we welcome the arrival of the OPT. Ophthalmic Nurse Education. Ophthalmic nurses working in their local units for many years have extensive experience of ophthalmic practice. They adopt skills to support patient care, develop significant knowledge of ophthalmology in their field of practice, and this is acquired simply through several years of experience, whether it's in a subspecialty such as medical retina or ophthalmic emergency services or cataract surgery. It's therefore envisaged that they'll have no problems acquiring the skills of level 1 in the OPT programme. And indeed, I think many already have many aspects of this. The problem, however, arises for new nurses. Relatively new to ophthalmology, they very rarely have any ophthalmic experience in their basic training. And when they come to us in ophthalmology, there's a huge gap that exists in their basic knowledge. Unlike our junior medical colleagues who join a specialty program in a training position, nurses are appointed into a post primarily to fill gaps in service, and acquiring knowledge is therefore often attained on an ad hoc basis. Without a formal postgraduate specialty training program, recruitment and retention becomes a concern. and there's no parity when competing for posts with other AHPs whose foundation training is embedded in ophthalmology, such as our colleagues, our optometrists and our orthoptists. So there's many challenges for us without a basic ophthalmic course for us. Consequently, recruitment becomes a problem, and we often end up poaching experienced ophthalmic nurses from other units as we all attempt to recruit from an ever declining pool of experienced nurses. Our in-house training is unregulated, it's not transferable, and it focuses on subspecialties which are where the nurse is working, limiting the nurse's area of practice. And it doesn't really allow nurses to practice holistically. Many specialty specific courses are expensive, and limited funding is allocated from directorate budgets to support this training. Often budgets cover all AHPs, and so there's competing demands on a limited pool of funds. I think we can all understand this really from our local areas. So Penelope has developed an amazing, well, she's certainly very much involved in a great initiative developing an ophthalmic nurse education program. It's a recent initiative currently in its formative stage, led by Health Education England. And the task force has been set up looking at much needed ophthalmic nursing curriculum and hopes to complete its work by the summer of 2023. It aims to fill the gap in postgraduate ophthalmic education and complement the OPT. The considerations really when we're developing training is very much about cost as well as service challenges. Ophthalmic courses cost, and educational funding needs to be available to support the training. Nurses are rarely given time in their work schedule to dedicate to study, and the conflicting demands on providing a service often competes to the detriment of training. There's further considerations to think about. Career progression is one, the agenda for change and the pay banding, very much a contested area in many units. There's limited career progression, and this can be demoralizing and de-incentivizes investment in higher education. This is really a concern relating to all AHPs. Nurse consultant posts are often optional and not embedded in the nursing career structure. Another concern. It's often viewed as optional or expensive, sometimes not even recognised by the nursing management hierarchy as worthy of investment. Just to leave you with this slide really before my next part of the presentation. The only thing worse than training your employees and having them leave is not training them and having them stay. And this is a pearl of wisdom that was a quote from Henry Ford, who's founder of the Ford Motor Company, and so true. So just to share with you really what the nurse consultant role is all about. I think it's if you're involved in a trust, if you're working in a trust that has nurse consultants, you very much know what it's about. But many trusts don't have nurse consultant roles. So just to give you a taster. The concept was introduced by the Labour government back in 1998, and the aim was to improve outcomes for patients. It provides professional leadership in nursing and creates a career structure in clinical practice, and it aimed to keep senior nurses in clinical practice. There's four pillars or functions to the role, and you could argue it's actually there's five. One is an expert function where the post holder should dedicate a minimum of 50% of their time in a clinical setting. The second is a professional leadership and consultancy function where you're involved in setting standards, promoting best practice. An educational, training and development function, and that's at local and national level. A practice and service development, and a research and evaluation function, where the nurse consultant is involved in developing local services, participating in development of national guidelines, and should lead in research activities. So how does that relate to ophthalmology? So I'm going to share with you my role in ophthalmology. I've been in post since November 2002, quite a long time, and subspecialties that I'm involved in is medical retina and glaucoma. And when the business case was developed for this post, it was looking at the workload in the department and where there was the um, the largest workload that needed support, and this was medical retina and glaucoma. So in medical retina, I was very much involved in macular degeneration, the photodynamic service, which was the service back then for treating neovascular AMD, um, and more recently the intravitreal service and diabetic eye disease. I was very much involved in developing the diabetic retinopathy screening program, which is now very much embedded in all our ophthalmic programs, and the glaucoma service, where I'm involved in screening and monitoring glaucoma patients, developing pathways for virtual monitoring, and I review unstable patients in the clinic. So what do I do? Well, my clinical function, if you go back to the headings, the 4 pillars of the consultant role, one of them was the clinical function, and at least 50% was very much involved in seeing patients in clinic one way or another. And in fact, it ended up being more 70, 80%. So my clinical function started off focusing on macular degeneration and the PDT service, and started from there. I review new referrals now, possibly with neovascular AMD, vein occlusions, DMOs, epiretinal membranes, macular holes, anything really that comes through the door that the optometrist feels is needing to be seen promptly. I developed the nurse-led intravitreal service. I review patients who've had anti-VEGF therapy, switch therapies, revisit the diagnosis if they're not responding to treatment. I also still undertake PDT laser, but that's very much on hold at the moment because verteporfin is kept aside for our oncology patients as a priority. But hopefully when it becomes available again, this will start up. I report on imaging for those patients who are managed virtually. So for the AMD service, patients who are in the stable phase of their condition are put into a virtual setup, and we review the images and write to the patients accordingly. So in terms of the organisational function, I'm instrumental in developing referral pathways, as mentioned previously. Develop virtual clinics, which provides increased clinic capacity, takes patients out of the clinic, and they are reviewed at a different point in time. And I developed the nurse-led intravitreal service. In terms of clinical function for glaucoma, it's very much about the virtual clinics as well as seeing patients in clinic. So the virtual clinics is where the clinician decision making is based on reviewing patients' data collected at another time and location. And actually patient satisfaction is very highly thought of in this service. So the 2 principles of virtual clinics is where the technician gathers the data but doesn't make the decisions, and the clinician makes the decisions but doesn't gather the data. It's that simple. And it's worked very well in glaucoma in the last 20 years. So I review unstable patients in clinic. I make clinical decisions based on visual fields, OCTs, fundoscopy, all the tests really that are gathered in the management of glaucoma. I initiate change therapy as needed to ensure adequate control and refer patients to the glaucoma unit if they become stable whilst they're under the clinic service. In terms of the virtual patients, we also have a virtual setup for our new referrals, and that developed pathway for new glaucoma referrals where they attend for screening and report on findings, and I discharge all the false positives and instigate treatments for those who are thought to have glaucoma or suspected of having glaucoma. So before we set up the virtual pathway for the new referrals, they were coming into clinic. This way they're being seen through a virtual setup. They don't need to take up capacity in clinic, and we can discharge all the false positives without them even touching our clinic. For the stable glaucoma patients, ocular hypertensives, as we mentioned previously, we report on those in a virtual setup, and patients get letters uh, giving them information about their findings, and also a letter goes to the GP. So in this way, clinical decisions are made based on the findings, and unstable patients can be referred back into clinic. It's very much a fluid movement between the unit and the clinic. And I also do SLT lasers. So in terms of a leadership consultancy function, there's national focus and a local focus. I was involved in the national guidelines for NICE in terms of looking at glaucoma in AMD, and I organise and chair regional educational meetings, run educational events, participate in national educational masterclasses on AMD, diabetic eye disease, and we've actually been looking very much at models of service delivery when capacity was very much an issue in the medical retina service. In terms of local focus, I've very much been involved in the educational events of healthcare professionals in-house, and I've been asked to speak at patient groups over time, including Diabetes UK. So research obviously is one of the big aspects of the nurse consultant role, and I was research lead for the directorate for 15 years or so, managing the budget, trying to grow the research portfolio for the directorate, and actually trying to involve other AHPs in participating and indeed leading on research projects. More recently, I've passed that research lead on to another colleague, but I'm still very actively involved in research projects, and I'm a PI for studies relating to my clinical area. Just before I finish, just to really touch on the drive behind the development of new roles. This was back in 2002, but I think the challenges still really stand today. So back then, the challenges were about recruitment. There were recruitment challenges, and they still exist today. Reducing junior doctor hours was very much a theme back then. We needed to fill gaps in service provision. We had an aging population, which we still have now. And as ever, there's a rising cost in healthcare and the need to provide value for money. So that was a drive behind developing nurse consultant roles, and I think they all still stand today. Just a reminder really that roles do need to happen for the right reasons. They need to reflect patient needs. They need appropriate levels of education, clinical expertise and support. And that's really why education is so vital, and it underpins our career structure. And of course, any new roles do need to be evaluated. I think that's the end of my presentation. Are there any questions at all? I know, Mel, you've been looking at the chat. Any questions for me?
I mean, I've definitely got some, but Andy Miller had a question in the chat, which was just, how does your role interact with the other professions, particularly the optometrists? And for everyone else, do feel free to pop your hand up, and if you have a question or just a comment about what's happening locally. So yes, what do you think about Andy's question about optometrists in particular?
Optometrists are a huge part of our service, and they've grown in numbers over time. I think as we've become we've struggled to appoint nurses, and therefore they're becoming less and less available to take on extended roles. Optometrists have filled that gap in beautifully, and we've been very much, my role certainly has been very much about developing their roles within our service. They now do intravitreals, they are involved in our AMD clinics. They're not involved in our glaucoma clinics as yet, but I'm sure that'll come with time. And my role really is about education and developing and supporting them.
Okay, and I hope that answers your question. Yeah, that's lovely. I just wanted to ask you. I mean, there's a lot of barriers, I think, as you said. And one of them, I think, was particularly important that nurses just don't have, and I think a lot of doctors don't know this, because doctors, whether they're trainees or consultants or even SAS doctors, whoever they are, they all have got to have built into their timetable one or more sessions to do stuff that is not patient facing and is not patient admin. So
Yes.
in your role, Mary, I'd love to know how much non-clinical time you have, and is there any guidance for either higher banded nurses, nurses in leadership roles, nurse consultants that people can refer to try and, you know, argue for some non-clinical time?
Yes, absolutely. I think that's something we're looking into now when we're appointing new nurses. We're putting a session a week. We're trying to put a session a week into their program so they can actually um, dedicate time to their own personal development. When I came into post, I had at least one session a week. Had one session for education and one session for research.
Okay, and is there any sort of guidance and I mean, what do people? I mean, your department obviously is far-sighted. They've got you, and you're now in a position to advocate for everyone else. But do you know what broadly do people do? You know, if you get a Band-Aid in general, does that give you some non-clinical time, or is it all dependent on your job, or is do the NMC have any guidance?
I'm not aware of any guidance from the NMC, but I think the band often goes with the role, and the role does need some admin time and it needs some education time. So it tends to go hand in glove in that regard. But I'm not aware of a formal guidance that says you need to have so many hours in your timetable.
All right, well, we've got a few hands up now, so I'll come first to Rob Cooper, the RNIB. Rob, do you want to unmute?
Yeah, so hi Mary, thanks for that.
Hi,
Just a
Rob.
couple of questions. You talk about you being instrumental in developing referral pathways. Two things that came up in my mind there was around mental health and well-being, and are you seeing, are you identifying people with, like, you know, emotional needs and mental health needs, and then making referrals to relevant agencies? So that was one thing. And then CVIs, are you involved at all in that
Yes,
CVI processing piece as well? So there were just a couple of things that I wanted to ask.
sure. Mental health, certainly. People with visual impairment, their mental health and mental well-being is impacted
Hmm.
hugely, particularly with AMD. And we have ECLOs. We have ECLOs in the department who are very much they're able to pick up that and support patients. But I can also refer to the GPs if I recognise this concerns in my clinic. So I'd refer to the GPs, I'd refer to ECLO, and we see patients regularly in the AMD service, so we can keep a watch on that aspect of things. The other thing you asked about CVIs, when we see patients who meet the criteria for registration, whether it's partial or severely sight impaired registration, we start the process off in the
Okay.
clinic, and then we forward the forms on accordingly.
So you start that process off then, and
Yes,
then that'll go to the relevant consultant to do
yes,
the
the
signing
signing.
off.
Yes,
Oh, that's good to
yes.
hear. Okay,
Yes,
thanks.
because we have the patients in front of us, so we can,
Yeah.
talk about, what support they have at the moment, and we can tick the right boxes and deal with that. Yeah.
Yeah, and I suppose just on the mental health piece, because you're seeing them on a regular basis, some of these patients, you'll notice any adjustments or changes and needs, won't you? So you'll be able to flag those and pick those up. Because I suppose the question we're asking ourselves around mental health support is, at what point does somebody tip over from just needing some low-level emotional support to actually full-blown, you know, therapy, counselling, etc.?
Yes, absolutely. And it can be quite an emotional time in clinic for some patients, so we pick up on those. Yeah.
Okay, brilliant, excellent, thank you.
It might be something to think about for as you take all this forward, and I know Penelope's going to sort of talk about the national stuff in a minute, is there is, I think, a research project going ahead currently about optometrists being able to sign off CVIs, because I think one of the things is, at the moment it's only, ophthalmology consultants, and what all that ends up doing is, because it's quite a straightforward process doing a CVI, there's absolutely no reason why other professionals shouldn't do it, but it limits access, or people are, asking for the CVI. So we need a wider range of professionals. I just noticed before I come to Penelope, I just noticed Laura's put a comment in the chat from the BMEC about that your CNSs band 6 and above have a session per week in the timetable for non-clinical things. So that's great practice, and I guess that's partly about being a large regional eye centre where actually you've got more idea of why this is important. But Penelope, did you want to come in?
Yeah, thanks, Mel, and thanks, Mary. You've raised some really pertinent points, and just to pick up on a few things is that, you know, I'm very I advocate for ophthalmic nursing. I'm chair of the Ophthalmic Nursing Forum, and really we need to maintain our identity as an ophthalmic nurse. And I would like to see, obviously I've got no sway in this, but that dedicated time should also be for band fives. We need to grow our own, and we need to be able to involve band fives into, you know, little research projects, literature reviewing, etc. So, you know, in an ideal world, it would be across the spectrum of ophthalmic nurses to have some dedicated time. And within our code of conduct, it says that we must practice on best evidence. So it just makes sense that we all as a team can appreciate what that best evidence is and understand that. In respect of the CVI, there is a project from Moorfields, but also I think it's with the a bid's gone into Moorfields and the Macular Society, but we're also looking at nurses signing off the CVI as well. It's gone through the first stage. I'm not sure, I don't know if anybody on the call that's involved in that, but I do know that that will not we, but that's being looked at, because that certainly would help, you know, get people through the system. And also in terms of mental health support, nurses have that education and training in their undergraduate programme. And the course that I run at Manchester, and I know a lot of other courses, that mental health and awareness of people with a visual impairment, with temporary and permanent visual impairments, that is integral to our practice. So I'm hoping that that is, you know, again, that's across the, you know, band fives and above, that we see that as part of our patient-centred care. Sorry,
Absolutely. Yeah.
Lovely. Can I ask a quickie, actually, if you don't mind? Just and again, this is something we debate a lot through the College of Ophthalmologists around when we have associate specialists and senior doctors who are not training and not consultants, and whether or not patients can be, you know, registered under them, or there always has to be this kind of ophthalmology consultant. So when you have patients, are they able to be registered under you as the consultant on your PAS, and you are the senior responsible clinician, or are they always still having to be under an ophthalmology consultant's name?
When I first came into post, when I set up my own clinics, I asked if my initials could be on PAS, or, you know, my clinic's under my code. Oh, no, you can't. You're a nurse. You can't possibly have that. So I ended up with some ridiculous code, which means nothing to anybody. Nobody really knows what it, you know, who's running the clinic. So that's a battle I'm still really having. I've got this weird code, and then I put MF at the end of it, so it has some kind of identification to me. But as nurses, we're accountable and responsible for everything we do, and we are responsible for the patients. And, you know, when I write letters, my name goes on the letters, and on Medisoft or whatever electronic patient record I use, my name is on there, but it's still under a medical consultant when, you know, requesting perhaps, I don't know, CT scans or something. I have to go to a medical consultant to do some things. So
Yeah.
it's not, and I think I would have to say that the service has an oversight from a medical consultant, so their name goes over the service rather than me.
Yeah, that's really interesting, because I think all of us as consultants, you know, we are accountable to our service lead and to our medical or nursing director. So, because I think that from what your description of what you're doing, really you are the responsible senior clinician. As you say, all that happens with fudges is it just sort of confuses everybody, but there's still a bit of a way to go. That's interesting. I don't think there's any more hands up, Penelope. So although there's a comment from Natasha, thank you for that. So yeah, I think that's a really good sort of point, is that you have to break the barrier, and once you have precedents, then it's easier. So I think Natasha, you got a question, haven't you? So do you foster and support aspiring nurse consultants in producing proposals or cost analyses?
Seems to be a drive within my trust at the moment to have cost cutting, and it's probably the same with many departments, and I suspect when I retire I may not be replaced. Of course, I always try and support developing expansion in practice, developing roles, and also support any education that goes on in the directorate. So if a nurse consultant role comes up again, people will be in a position to go for them. Whether there will be another post, I don't know. I don't know.
Brilliant, thank you very much. Okay, so Penelope, do you want to carry on with your presentation? That'd be great.
Thanks, Penelope.
Thank you. I shall just move my slides forward. Yeah, thank you very much. So leading on from what Mary was telling us about the nurse consultant role, I'm going to talk about ophthalmic nurse education, past, present and future. And I'm
so sorry to interrupt, but the slide hasn't moved forward for the viewers.
Oh, thank you.
There we go, perfect.
Yeah, okay. So yeah, I'm very biased towards now I've frozen, I can see. Can you hear me? Yeah,
we can hear you absolutely fine, thank you.
Yes.
Okay, thank you. Yeah, so yeah, I'm very biased towards ophthalmic nurse education. I work in ophthalmic nurse education at the University of Manchester, where I run an online ophthalmic nursing course. I'm also chair of the Royal College of Nursing Ophthalmic Forum, and very involved in lots of strategies to support and champion the ophthalmic nurse, and to keep our identity. I've been an ophthalmic nurse for a very long time, and you know, I suppose that's central to my very sort of professional and personal being, the care of people with ophthalmic conditions. Now, I think as well, for us as nurses, but also for our multidisciplinary team colleagues, we need to have a definition of an ophthalmic nurse. We don't want to, again, it's about maintaining our identity. So the RCN have recently, or about to publish the nature, scope and value of ophthalmic nursing document online, which is a historical document that we update every few years, that talks about what is an ophthalmic nurse, what do ophthalmic nurses do, and what are the components of ophthalmic nursing care. So the definition there is you know, the key thing there is that we have the education and the expertise. If we haven't got the education, we can't have the expertise, and that contributes to this holistic approach to nursing care. And it's supporting our patients and caring for our patients with visual impairment, and that could be temporary, permanent, and it's wherever they may be, because we've got we're caring for patients in research facilities, in the independent sector, in the NHS, in primary and secondary care. So it's sort of taking that broad approach. But what does an ophthalmic nurse do? I mean, I've put a list there on the right-hand side, but it's not exhaustive. But we do a lot of things. So we look at the biopsychosocial. So we're looking at the psychological impacts, as well as the bioscience behind that. We're educating. We're doing lots of things that are not just about caring for the ophthalmic condition, because that wouldn't be holistic care. And you know, we do research, we might have a technical role as well, but all of it is combined to the whole thing. So why do we need education? Why do we need ophthalmic nurse education? And it's quite clear in the global and national literature why it's important to have the right education. And I'll mention a bit about what I think the right education is. But recent reports, 2019 and also more recently 2022, the World Report on Vision says that we need to promote a high quality health system. So a high quality health system is having nurses do the right thing, be able to do the right things, be able to care for the patients effectively and promote the best outcomes. It's also part of safe staffing. So safe staffing isn't about having X number of nurses. It's about having the staff that have the right expertise to be able to care for those patients effectively. And I'll just take this quote from the RCN Safe Staffing campaign. And it's about developing existing staff. So leading on from what Mary was saying, it's part of safe staffing to be able to have that, I suppose, a development pathway for our staff to make sure that that they can do the job that we want them to do, but also it helps them to stay, and therefore we're filling gaps, or we're not creating gaps in our complement of staff. Also part of NHS England Eye Care planning, and been very fortunate to be part of the eye care workforce planning team, and really emphasised the role of the nurse as a nurse, not a nurse as a technician or a nurse as doing a task. And also it's part of our NMC code of conduct that we have the right education, skills and expertise, and understand the evidence to support our practice. So it's in a wider context about why it's important for to be educated. And Mary touched on what ophthalmic nurse education has, how it's evolved, or I say it's evolved and then it's taken a big dip. Quite a few years ago, we used to have the pre-registration ophthalmic diploma, where we had cadets who did that before they went on to do their registered or enrolled nurse training. Then we had the ophthalmic nursing boards that offered the nursing certificate and nursing diploma in ophthalmic nursing, followed by the EMB. And now the ophthalmic courses are integrated now into higher education institutions, and they're regulated by the higher education institution rather than the board, rather than the NMC. And also they have the advantage now of being able to be part of a pathway, a master's pathway, a degree pathway, and they'll have the ophthalmic courses, which is common to all of the higher education institutions. They'll have credits attached, and they can be fitted together to form a degree with other subject areas. But I talk about ophthalmic education now, looking, reflecting on my education as an ophthalmic nurse. I had a great experience where I achieved, I worked in every area of ophthalmic nursing practice. I was fortunate to undertake a lot of skills. But now because the EMB and OND are now no longer, we find that there's not that many ophthalmic nurse education courses across the UK, and I now feel that we really need to level up with our multidisciplinary team colleagues who have got a background, who've got an undergraduate qualification in optometry, orthoptist, but they've got that sort of basics, if you like, of understanding about A&P of the eye, etc. And as a undergraduate nurse, there is no formalised exposure to ophthalmic nursing. or whether that be theory or whether that be practice. It's very ad hoc, and depending, you know, if a student just happens to get placed in an area where ophthalmic care takes place. But I talk about education in terms of, I've used Dewey's definition there. Education is about creating conditions for individual growth, but it's very much about critical thinking. So I mean from that is that we need higher education institutions to be able to provide that education. So learning a task does not provide conditions for critical thinking. It provides the competencies to do it correctly, but doesn't take into the wider aspects of that care. Also from the RCN Ophthalmic Nursing Forum, we believe that education conditions, such as mentioned by Dewey, so that those conditions for individual growth, those conditions for critical thinking, should be part of a validated ophthalmic nursing course where the student's knowledge is assessed. So moving on then to what we're going to do about it, the Health Education England did an evidence review in 21 to look at how many institutions were offering ophthalmic nursing courses, and there's probably about I mean, it does change over time anyhow, but there's probably about 5 in the UK. One in Scotland, a few in London, but things are changing over time. And of course, I've got my course at the University of Manchester, but things do change, and I know there's other courses popping up as I speak. So, but it's that access. So if it's not there, what we're going to do about it, and that again is part of the NHS eye care workforce transformation. You have to have a workforce that can have those opportunities to access education so that it can do the job properly, and therefore this facilitates optimum patient outcomes. Now, with that, just some of you are probably aware of this, but I'm just to inform you that I'm leading a project funded by Health Education England, who are now incorporated into NHS England, and I'm looking to develop, or I am developing, a national standardised curriculum framework for ophthalmic nurses. And this has come from working on the eye care transformation, is that they recognise there needs to be a course, but there needs to be that education, like the Dewey quote. It's those conditions for individual growth and critical thinking. So there needs to be a course that is consistent, that reflects ophthalmic nursing today. And so the aim of that project was to explore what that means. What is a curriculum framework for ophthalmic nurses? What do ophthalmic nurses need to know to be able to provide that care? And currently the curriculum model is only looking at theory. However, as time moves on, we're hoping to develop the practical component and then make those links. But at the moment, we're looking at what do ophthalmic nurses need to know subject-wise, what learning outcomes. So it's been framed in the level 6, which is sort of degree level learning, and level 7, which is masters. And we've had a task and finish group, and we have our third task and final task and finish group next week. And then we will, the curriculum document will go out to a wider group of ophthalmic nurses, stakeholders, and that will be supported by Skills for Health. Just to note, the task and finish group has, we've got optometrists, orthoptists, ophthalmic scientists, nurses, so everybody that can have a contribute to this because they, you know, we all work as part of that team. But this curriculum is nursing. It's about ophthalmic nursing. The main themes is that the group very keen that anatomy and physiology, altered physiology, things like interpretation of investigations, etc. But also, if you note there, that's what it's the critical skills. So critical skills are inherent into what we do. So it's not just about learning something, but it's about that notion of critical thinking. And the positive feedback, we need this curriculum. And then what is out of scope at the moment are these practice objectives and clinical competencies and the delivery of the curriculum. But we're, you know, that these are things that we're building on. And before I said about levelling up, having a national standardised curriculum, which is robust, which is quality assured, this is the, you know, the role of the higher education institution, means that it's consistent. So if you have a nurse, you know, you employ a nurse that's got the ophthalmic course from Birmingham University, for example, then you know that they have followed this curriculum, and also that they've been assessed, their knowledge has been assessed. And with that will be, you know, a written assessment, an assignment, an exam, posters, lots of different ways that can be done. But you know that they've had there's been a rigorous approach to that assessment. So I won't talk too much more about that, but again, it's emphasising that need to level up, and that need to level up is really relevant for the ophthalmic practitioner training, which is the OPT, which is it's now known as, it started off as the Ophthalmic Common Clinical Competency Framework. A lot of long sentences, but the Royal College of Nursing have been involved in the development of this curriculum since 2014. It was launched officially in 2019, and this is a national core competency curriculum framework, and it also promotes consistency in practice. And this is for our orthoptists and optometry colleagues and other colleagues with backgrounds in educational backgrounds in ophthalmic care. But as I said previously, we do not have, as nurses, not all of us, but some haven't got that grounding, that educational underpinning to be able to sufficiently undertake this this competency training. And just directly to the quote here from the 2016, the original publication of the document, that people need educational opportunities to provide that basics, those basic grounding for ophthalmic. Now, I won't go through the OPT in much detail because we had the educational lead from the Royal College of Ophthalmologists a few sessions ago, went through this, but this is a great way of integrating your theory, or what, you know, the education that you've had, the validated education, with clinical practice, and be able to undertake core competencies supervised in your own practice area. And there are 4 areas of care and 3 levels. The 3rd level is a little bit different in that it also needs to undertake a master's programme and the outcome will be an advanced clinical practitioner. And there are lots of universities around the UK, such as Aston, Plymouth, Sheffield, I think, are doing the ACP programme for advanced clinical practice in level 3 with the OPT. So you're already doing that, doing sort of leadership and management, education and research, etc. And these are funded by the apprenticeship levy. So that is something really, I think, for the really great for all of us of ophthalmic nursing. So when it comes to level 1, to actually get on the OPT, it's ideal that you have some sort of ophthalmic education and not necessarily an ophthalmic nursing course. Some nurses have done the College of Optometry higher quals, or may have an ophthalmic science background, etc. But I just want to draw your attention that we're looking at a level 0 for the OPT. That's not been finalised yet, but I've worked on that with a colleague, Zena Rodriguez at Imperial, and we've mapped what undergraduate nurses will come out with that we can transfer onto the OPT. And all nurses have come out with this standards of proficiency, and one of those is communication. So I'm just using that as an example there. And the OPT level 0, so mapping to what would be at level 0 would be, it's CA1 here, it's conduct consultation. So as you can see, there's lots of commonalities, transferable skills from the undergraduate nursing programme. So apply the communication skills you acquired in your previous training to, and then that's something that can be signed off by the supervisor. Level 1, again, it's quite wordy, I'm not going to go through it, but I can just show you, point you to the highlighted in red there, is that most nurses will be able to, after doing an ophthalmic course, will be able to have completed level 1, and that's just a matter of being signed off by the supervisor. There's some partial there because they may not be competent because they may not have done a practice component for the ophthalmic course, so they may need provide further evidence or be supervised to take a comprehensive history, including risk factors for ophthalmic disease. And then level 3, this is all associated with the advanced clinical practitioner training and the master's degree. So that needs full evidence. So I'll talk about evidence. This is a portfolio-based competency training, and the student or the learner would compile a portfolio. There are regional leads all over the UK to support the education of ophthalmic practitioner trainees in practice, and there should be some supervision. For the level 3, nurses would need to apply for the apprenticeship levy through their workforce, and that is actually, there should be money available to support that. Well, there is money available for that. So I'm just check the time, just running out of time a little bit, but it's important. I mean, it's important as far as I'm concerned as an individual and as a professional, but we need to take ownership of ophthalmic nursing and our future and be part of workforce planning. We need to, there's more mapping to be done to align curricula to the OPT levels, but also you may be familiar with the enhanced clinical practice offer apprenticeship, and it may be in the future that we'll be able to make some links between the curriculum that I'm developing and also the enhanced clinical practice. So there are other specialities that are doing enhanced clinical practice, which is related to theory but very much competency based as well. And there's generic competencies, but hopefully be able to work on some ophthalmic competencies. And again, this is supported by the apprenticeship levy currently. So there are opportunities there to take that learning further. But also one of the things that, you know, that Mary said, it's about the financing, isn't it? So if we can use the apprenticeship levy, etc., that you know, that's a great way forward. But at the moment, that's still in development. So I think that's all I have to say. Yep, so thank you very much. Whistle stop tour of what's going on. Just we've just got to work together. We're a team. We're a force in ophthalmic nursing care. So I'll leave it. I'll leave it there. So yes, so I've got some questions. I don't think we've got time for any questions.
We've probably got a little bit. I think we've got on the agenda. We've got till 22 potentially.
Oh right, that's okay. Yeah, no, I agree. There's not enough focus on ophthalmic nursing in undergraduate curriculum, and I work in undergraduate as well, and it's you know, you're fighting a battle all the time to be able to get people to, or the curriculum planners, and to recognise the importance of ophthalmic care. And everybody's okay. It doesn't think about it until they've got something wrong with their eyes, and then they say, "Oh, didn't realise." And but yeah, it's just an ongoing thing. I mean, back in the day that we used to be registered with the NMC as ophthalmic nurses, and of course that's gone. That I have looked into how we could be registered with the NMC, but it's just not going anywhere at the moment. But yeah, definitely the emphasis. But then, you know, other specialities will say the same about there. So it's like we're all competing. But not, you know, not everybody gets cancer, but everybody's got eyes. So yeah, so I don't know the answer. I know what you know, if I had a magic wand, what the answer would be, but in the real world, no. Oh yeah, yeah.
Do you mind if I ask you something? Just
Yeah.
about. So I think I just want to get my sort of head straight, because I think, you know, as you know, there ended up being quite a lot of politics around the OPT from the different sort of professions, because obviously, you know, when you already have existing things, then you know, people can feel a bit sort of nervous and threatened about, oh, what's this other program that's so. Could you just explain again, just in words of one syllable for an idiot like me, if you've done the ophthalmic nursing curriculum, what will you've definitely covered in OPT? That's first question. And then the second question is, because I think this is a real issue, say for the optometrists, are we going to be able to get the Royal College to acknowledge that this is done? You know, if you've done this other course, you do have level 1.
Yeah, and I think the issue is with APELing, which doesn't it needs working on with the OPT and the Royal College of Ophthalmologists. They need to be able to APEL, and I think the problem is knowing, particularly with nurses, is knowing what they've done. So if I'm APELing a student on, I don't know, sort of leadership course, I can see what they've done. You know, they'll give me their learning outcomes or whatever, and I can see what they've done, but it's that lack of transparency that isn't available. Because as well as a Royal College of Nursing, we don't have that the regulation like the College of Optometrists, so you don't know what we know what an optometrist has done. We know what the learning outcomes were and what they've been assessed on. But yeah, that's the thing is the APEL, and I think they want them to, and because a lot of things are not consistent. So for example, VA, for example, how have we learnt how to test a VA? How do you know that the nurse that you've got working in department, where have they seen one, done one? Have they done the theory on it? So you can that sort of thing needs to be mapped, and it may be that you want to assess that nurse on that particular aspect of care, and that's not a one syllable answer, is it? But
no, I think it's true. And Andy's sort of made a comment again. I think it's just that kind of, you know, that people have got limited time. Okay, we've already said this, particularly people who are not medical but are clinical professionals in their timetable to do all this stuff. And what people really don't want to do is have to do it twice. And I think what we don't want is a situation in which, say, a nurse or an optometrist has gone through, you know, an accredited, transparent, open, good process, and we know that they can do this, 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 and this. And then we have another system going, that's great, but we don't acknowledge that. So you'll just have to do our qualification, and no doubt you'll then be able to do it really quickly. But that is not practical. So I think that you have got an opportunity here, because what you're doing is under HEE or the NHS England workforce people now, as is the OPT, to really be able to get over that barrier and make sure that mapping is done, and that is absolutely, if you've done it in one process and it's equivalent, you do not have to repeat it, that's absolutely acknowledged. I think that's really key for the uptake of this, just practically, because you know, so many units are under pressure.
Yeah, and definitely this is the aim of the national curriculum that I'm working on, is because they have that, because then it's, it is transparent, yes, and then move on. It's the things that aren't transparent that somebody's just done a training course somewhere and things like that. So, but yeah, so when we've got this nationally recognised programme, such as the ophthalmic nursing course, but also the OPT, because I really advocate for the OPT because it's national. So and it's transparent and consistent. So if you've done the OPT in Moorfields, you don't have to redo skills that you've already been signed off for when you go and work at Manchester. So that's the beauty of these things. And again, it's about time, isn't it? You know what you're getting when you employ somebody. Yeah. Also, they're great for recruiting and retaining staff, because you can put staff on a pathway. In 1 year you'll do this, in 2 years you'll have this qualification, and it gives them something to be valued for as well as work towards.
I think that, because I think Andy again making sort of, and this is again another tension, this kind of how you respect and utilize the individual professionals, their particular areas where they're sort of grey, and yet also acknowledge that multi-professional thing. And I think that's really difficult, because you both illustrated earlier this whole, there is something extra that nurses bring that, to be honest, in my view, isn't quite the same in all the other ophthalmic team professionals, and we don't want to lose that. But equally, we don't want a really if people are broadly then coming together to be consultants, advanced practitioners, we also don't want something that then looks completely different for optoms and orthoptists. And I suppose that's where the OPT brings things together. But I do think that is tension, to keep our individual, what's good about our individual roles, but recognise what is the same in our individual roles.
Yeah, and the optometry and ophthalmologist colleagues have recognised that we have something that they don't, and they need to learn from us. But we doing this approach, I think, OPT and the national curriculum means that that we are levelled up in terms of career progression, like Mary was saying about, that nurses have the same opportunities as the optometrists do for when it comes to applying for post promotion, etc. And I suppose just the question that often is asked is, who takes the patient to the toilet? And that is a great leveller.
That's a good note on which to end.
Yes, I think we'll finish on there. Yeah, shall we move on? Yeah, and I'd just like to thank you, everybody, for listening, and introduce you now to our chair, Melanie Hingarani, who's going to talk to us now about the associate membership of the Royal College of Ophthalmologists, which was quite exciting. But I'll leave you to it.
And then both Mary and Pilar, you've been very helpful in helping to develop this. So thank you. So I'm actually talking to you really in many ways in my role as honorary secretary of the Royal College. So I thought it's worth just before we get into the details of the new membership, just to sort of remind people about what the College of Ophthalmologists is and what we do. So basically, we're an independent professional membership organisation, and we're a charity. So, you know, very similar to things like the College of Optometrists and Royal College of Nursing. We have a royal charter and bylaws. But we can change our own bylaws with, you know, agreement in the college, but the charter can only be changed with Privy Council approval. And in terms of our purpose, we describe ourselves as a college advances the science and practice of ophthalmology through leadership of and advocacy for the profession and practice of ophthalmology with patients, the public and wider stakeholders, through training, education, research and study, and through setting and maintaining standards for training and practice. And we were actually a relatively recent Royal College, because if you imagine, some of these Royal Colleges are terribly venerable and terribly old. And we were actually founded in 1988. Initially, we were a medical college. We weren't royal at the beginning, and we came out of the Royal College of Surgeons. So basically, it was a merger of two societies. So one was the Ophthalmological Society of the UK, which basically ran these annual scientific meetings, which are basically similar to the Congress we have now. And we had a faculty of ophthalmologists, which was within the Royal College of Surgeons of England. And then later on, well, in 1993, we gained the Royal Charter, and we are the RCOP, the Royal College of Ophthalmologists. We're not the RCO, which, as it turns out, is the Royal College of Organists. And the college gets upset that the people don't know that. So now I'm just hoping I can advance my slide. Okay, so in terms of sort of, you know, everything's evolving, and I think the talks we've just had are an absolute, you know, prime example of that. So the nature of our services are changing, and that the, you know, the wider multidisciplinary team are of course now delivering a much wider scope of practice, including many of those aspects which would have traditionally been delivered by doctors. The college itself has also had to evolve, and when it was set up, it was very much about, we have these 5 departments, and we do the quality and standards, the exams, the training, the scientific, which is the meetings and the guidelines. But actually, what we need to do is so much more. We need to do policy, campaigning, and influencing government and NHS England and Wales. We need to look at equality, diversity, and inclusion in ophthalmic services, and our values and transformation of services, and that doesn't fit neatly into any of these departments. And so the college itself, its structure and the way it works is evolving to reflect that need to work across silos and do different things now. So the associate membership is a new thing, and it's it's membership of the Royal College of Ophthalmologists for people who are not ophthalmologists, which at the moment does not happen. So we have sort of, we're starting off with two areas. The first is what we've termed ophthalmic practitioners. So these are registered professionals within the ophthalmic team, so nurses, orthoptists, optometrists, and healthcare scientists, and also early career doctors, or not even doctors yet, medical students and foundation year doctors. And the expectation is that for practitioners, nurses, optometrists and orthoptists, that they will continue to be members of their own professional body. That's super important. This will be an add-on, and we feel it's likely to appeal to those with expanded, extended practice, advanced practice, looking for those sort of bits that perhaps their own body doesn't offer, because their own body, the vast majority of people, are perhaps not doing this sort of work, or not in ophthalmology specifically. It's multi-specialty. In terms of how we developed this and what benefits we wanted to be able to offer to our new members, we liaised with small focus groups of people who we felt were likely to join from each of the professional groups to see what they thought. We also made sure to contact other colleges or BIOS to make sure that they both understood what we were doing here, and this wasn't meant to be in any way a threat or to poach people, to ensure that there was support. And I have to say, I'm absolutely delighted to see that there was actually no defensiveness whatsoever, and all the other organisations for each individual professional were super supportive, which is absolutely amazing. And what we hope to do is, we sort of thought it's pragmatic to make a start on what we think the offer should be, but we don't want to do things to people. We really need to develop the offer with going forward with people from those professional or early career groups, so that we sort of start to get new members in, and hope that those new members can help us to understand much better what members like themselves would want to see going forward. So in terms of the benefits for the practitioners at this point, there'll be access to the members area of the website, so the non-public area of the website, be able to come to various webinars, educational meetings, access clinical guidelines and so forth. I think a really big draw is, and this is quite a new thing, we've launched a thing called Inspire, which is an electronic education platform. So basically you can get meetings, talks, resources through electronically, and that's only available to members. And there's quite a lot of content, but again, we need to develop more content with members. And also included in membership will be enrolment to the OPT. Not everyone may want to do that, but for people who are enrolling in OPT, that will be included in the membership fee. There'll also be access to the college's iJournal, which is published by Nature online, and members will receive our various sort of publications for members, keeping them up to date with whatever's going on. So that's a sort of 2 weekly newsletter email, and also a quarterly more sort of magazine style college news. We have to be mindful to sort of at this point probably differentiate different members, partly because the fee is much less than full members. So the new members will be able to speak at the annual general meeting, but at this point, at least, will not be able to vote for the president or the medical regional representatives. And then there are various kind of discounts and benefits on stuff, things like lifestyle reward and totem pros. So some of them are slightly more kind of fancy upmarket things for discounts, and some are slightly more kind of basic things. We will be offering a discount at Congress, not this year, but going forward. At the moment, the fee for Congress will still be the old, what they used to call the AHP fee. But the reason I can't tell you exactly what this is going to be is that we're doing a pricing policy across the whole hospital to try and make it fair, transparent as to who gets what, because it's a bit random at the moment. And we also have a new communities platform, which is in the process of being launched, which allows people to create groups and start to network online, to share documents, to work together and make connections with people all across the country. So we would expect that people will start to form these groups and network with each other through the college. So now I had to change my slides this morning because actually this opened soft launch this Monday. So if you wish to leap away from this meeting and go off and apply, you can. So I've put the little email there, and there will be some communications going out, and then there will be more of a full launch and kind of whole marketing thing. But we're sort of starting to send the message out. So at the moment, the fee is going to be £70, and obviously people join later in the year, you get a reduced fee because you're only joining for 3 months rather than 6 months. And also a recognition that the offer is not yet fully developed, and as the offer gets better, then we need to review that, but we're always aiming to keep the fee below £100. And then we really need people to join so we can start to develop the ways of working. And we want to start to get people to sit on committees and groups that exist, form their own groups underneath the college, develop the membership benefits. We need to start developing prizes and awards and events and things which will be of appeal to people. And then where do we go from here? So, and again, ideas welcome for groups I've missed. So thinking about, healthcare assistants, healthcare support workers, and the really burgeoning technicians in eye care, we need to think about them. I think ophthalmic pharmacists would be, for me, another early group. some of you may know that the college is about to, or shortly launching a pilot for physician assistants in ophthalmology, funded by HEE, NHS England. So they may be, if that looks promising, there may be another group. There are, of course, doctors and other professionals who may be quite interested in eyes, but they're not within ophthalmic services. So within GPs, in A&E, in neurology services. And I think that this is something I'd be really interested in, given what the UKOA has tried to do for putting clinicians in touch with service managers and vice versa. And I think that it would be really great to think about in the future, trying to get people who are really long-term ophthalmology service managers or executives for having a membership for them as well. So that's really all I wanted to say about that. So, but obviously happy to take questions and comments.
Just to say thank you very much, Mel. I think that's a really exciting new initiative, and it's a really good opportunity for other ophthalmic healthcare professionals to network together. We don't really have that opportunity on a national level like that.
Yeah, I think that, I mean, it has been interesting because, as I say, we were a bit worried about, you know, how some of the colleges might view this, and yeah, I think we might ask Andy to comment in a minute. But I think the thing is, if you have something like the Royal College of Nursing or the College of Optometrists, you know, they've got thousands and thousands of members, and they have to create the offer on really what the majority of members, and it's harder to do sort of niche. But Andy, I don't know if you just want to come in and sort of comment, because you've been very enthusiastic in the chat. What's your view of the associate membership, and will you be joining soon? Oh, we can't hear you. Could you just unmute? Sorry.
Oh, these modern technological things. I think it's a fantastic idea, and I know that the College of Optoms are doing the same. So it would be interesting to have a chat with the Royal College so that we don't tread on each other's toes. I would like us to work together, not against not in competition. So, and there's some areas where we could be stronger, and some areas where you could be stronger, and we could focus on those. But I think it's a fantastic idea, and especially with the voices from other professions, that's going to be the important thing. So I think the number of daft decisions in the future is going to plummet, because somebody else will go,
Yeah, I think that's true. I think we need that in. I mean, if somebody said to me, you know, would you, for a reduced fee, join the College of Optometrists, I might well, because, you know, I've been really keen on promoting optometry, you know, within the sort of the pathways, and you know, it's good to get inside each other's sort of shoes, I think, because what often happens is we do whatever, we make the decisions, whatever we think is right within our own little organization, and then we sort of take this kind of thing that's like 99% done. Well, we think this, comment if you dare. Actually, yes. You need it to be, you know, you need these things to be co-developed, as you say, from an early stage, so you don't just come up with something done, or just something that's going to put people's backs up, which is very counterproductive. So yeah, thanks for being supportive.
And sorry, and I would add as well, it will start to break down the thing that I said before about the different professions valuing each other's education. You know, if we start interacting, it's going to show each other that we, you know, the others haven't got two heads or anything like that. And they're professional, just like we are.
Yeah, and actually, as Helen just put something there, and I think actually, yeah, so certainly, I mean, ECLOs, actually, I haven't got ECLOs on my list, have I? Yeah. So I better add those. And I think that, you know, you've got to start somewhere, I think. So this is probably going to be people who are most akin to what ophthalmologists do, I suspect, is where the first path lies, and that's why we've gone. But I do agree that we do need to think about, there are lots of people who are involved in the eye pathway who don't really have a home to go to. So yeah, I think, you know, we could take this as far as we want. So yeah, thank you.
Thanks, Mel. The thing is getting that message out there is promoting it, I think, because how would an ECLO know that this opportunity exists. So I think that probably needs to be thought about. I mean, the Royal College of Nursing will put something on their website, because, as you know, we're very pro this, and I myself will be joining. But yeah, I just wondered how you get that message out then to other professions.
So I think so at the moment we have only opened, and we've only developed the offer for the nurses, orthoptists, optometrists, and I think healthcare scientists. There's not so many of them, but they're registered. And then and we already have reasonable communication channels for foundation doctors and medical students. And in fact, there's already some have applied amazingly. So we will be working with the stakeholder. So we will be, if we haven't already, be writing to you and to buyers and everything, so saying, right, but what we wanted to do is we just sort of sneaked it open just to tease out any teething problems. And then when we're happy, it's all working okay, then yes, we will be asking you to please help us with communication to your members and to your colleagues to make sure that this is the case. Now, we do not at the moment have a category for, say, ECLOs or technicians. So I think one thing at a time, let's get what we've done right and get it all working. And then when that's looking nice, we then move on. Because I think you can, if you scattergun and try and attract everybody, we could fall over, because this is, as you can imagine, for some people, quite a big step. Because we are the Royal College of Ophthalmologists. And is this the first step in the move to being a College of Ophthalmology? That is a big thing. So I think yes. So we will target the people that we've identified first, and then yes, look to expand to ECLOs or whoever it is later on.
Yeah, that's great. And seeing the chat that Helen's kindly offered to promote through the RNIB. So thank you, Helen, for that. But yes, that's something to think about. A Royal College of Ophthalmology. Probably in about 20 years' time, perhaps. But it's a great thought. Any more questions before we leave for
I think
today?
I'm just going to say, in time, Mel, we can all play a part in promoting this to our ophthalmic community, couldn't we? So I think when the time comes, we will be there to support that.
Yeah, and through the UKOA, and then the trusts can disseminate, can't they? So there's lots of opportunities to do that. And while we're plugging, the Ophthalmic Nursing Forum opens for the steering group applications in May, in a few weeks. So we're really looking forward to anybody that's interested in applying, and please do get in touch with me if you'd like a chat about it. Joint e-learning, that is another thing. Again, as we're part of the same organisation, then the e-learning from all perspectives, that's a great idea. Yeah,
we're just about to look at a whole thing of leadership in eye care, so it's something like that.
And that's great, and that's what a lot of the universities do with the ACP as well, is that it's looks at it from all perspectives. So for example, with leadership, but that'd be great for the Inspire platform. Okay then, so no, I can't see any hands or any further questions. Thank you, Helen, for your I'm glad you enjoyed the session, and I'd like to thank Mary Freeman and Melanie Hingaragi for their contributions for today, and also for yourselves for listening. And I do hope that you're going to be able to share and discuss and reflect on your practice as part of your engagement in this session. So thank you all, and the next one will in June, isn't it? I think the next one. Yep. So look forward to seeing you face to face. Yeah.
Look each other in the face.
Yeah. Okay then. Right. Well, have a nice weekend, everybody. Bye-bye.
Thank you. Bye-bye.
Bye.